Prof, you're still on mute if you are saying something. Yeah.
Oh, hi everyone, and welcome to the 2025 Nisa Research Week. And co-facilitating with me is Dr. Cornelius Ewosho. Dr. Ewosho, can you say hi and show yourself? We want to welcome you all to a great week, 5 days of engaging presentations, arguments, questions, whatever, very interesting. And with me is Dr. Cornelius. He is an assistant professor at the Steve Biko Center for Bioethics at the University of Witwatersrand in Johannesburg, South Africa. So all the way from South Africa, Cornelius will be facilitating this session with me. We're happy to have everyone here. So over to you, Cornelius.
Thank you so much, Prof, for the very kind words. And I think I also echo your sentiment when I say to the many people who are joining us for this webinar that we are super excited to have you join us for this week-long event on the role of implementation science in sustaining health programs. I imagine that this event in fact, this event promises to be enlightening. We have managed to also line up speakers who have dedicated many years to studying issues in implementation science. Our speakers are recognized. They are recognized leaders in the field, equipped with extensive research networks that I think we can benefit from. They also have a wealth of experience in addressing significant challenges related to sustaining health programs through implementation science. We are indeed happy to have this engagement with them. For today, our speaker that I will introduce shortly will explore critical issues around what ought to happen to advance implementation science in health and healthcare. Where are the challenges? And what movements do we need to make to advance implementation science in health and healthcare? I am very pleased, very delighted to introduce today's speaker, Dr. David Chambers. I'll just try and share now. Just 1 minute. So, okay, yeah, here is Dr. Chambers. I think can you see my screen if it is working? Yeah, excellent.
Yes.
So Dr. Chambers is the Deputy Director for Implementation Science in the Division of Cancer Control and Population Sciences at the National Cancer Institute within the National Institute of Health, I think, if I'm correct. And he joined the NIH in 2001 and has since been responsible for managing the dissemination and implementation research program within the Services, Research, and Clinical Epidemiology branch. He collaborates with his team to achieve this through funding opportunities, training, dissemination platforms, and partnerships that aims to integrate research with practice. And in addition to his career at the NIH, Dr. Chambers is also a football enthusiast. At one point in his life, I think he played as a goalkeeper, and he continues to nurture that interest. I think, Dr. Chambers, my team, Manchester United, should link up with you at some point. Maybe, I'm sure you have so many things to teach that team. In his spare time, Dr. Chambers also composes music and plays the guitar. So he has a very successful research career and an active social life too. At the same time, something that I think is really worth learning. However, before Dr. Chambers speaks to us, it will be remiss of me to neglect to mention that Dr. Chambers also wants this presentation to speak to some of the pressing questions you probably already have around implementation science. I would also like to learn how your own research experience influences the way you think about these questions, which implementation scientists ought to take seriously. As a result, what we have done is to set up a pool that should take no more than 6 minutes for you to complete. The link to this pool will be dropped in the chat box, I think, Dr. Tonya. So we want to, it's already there, excellent. So yeah, we want to really invite you to please use this link to complete the pool. We would show the results of the poll just before Dr. Chambers speak. Please, if you can do this now, we would greatly appreciate this. And as you respond to the poll, let me also introduce Professor Echezona Ezianoluwe. Prof. Ezianoluwe is an outstanding scholar and a professor of pediatrics. Professor Ezianoluwe is the founder of the Nigerian Implementation Science Alliance and the director of the IBAN Research Institute in Nigeria. He has many years of experience in researching infectious diseases, designing clinical trials, and leading various projects related to implementation science. His research specifically aims to bridge the gap between implementation science and practical application. And he achieves this through the development of research infrastructure, research networks, and programs focused on development of investigators. Prof has authored over 100 peer-reviewed publications and served as either a principal investigator or multiple PI on more than 25 peer-reviewed research projects. Prof, we are really excited to hear you share your vision for implementation science research with us and your planned activities for the future. So before Prof also speaks, Prof will speak first before Dr. Chambers speaks. We have decided to put it this way because we also want to show the results before Dr. Chambers starts speaking. And they want to do that right after Prof has shared his thoughts for us, share his thoughts about implementation science with us. So while Prof is speaking, could you please respond to the poll? Would appreciate this. Also be aware that this session is being recorded and live streamed on YouTube. So we encourage you to use the Q&A feature to ask your questions. If you post your questions in a regular chat, we may have trouble tracking them. So please utilize the Q&A function in Zoom for the best experience. So Prof, over to you. I would hand over to you now to allow you to say something to us before Dr. Chambers speaks. Thanks.
Thank you so much. I hope you can hear me. I'm in transit and I'm at the airport. So if you do hear announcement, please know that that's where it's coming from. Can you hear me? Cornelis, can you hear me?
I can hear you, Prof. I'm trying to, I want to stop sharing so you can, okay. Yeah,
all right, Ikenna is gonna pull up a little bit of a slide. And remember, the whole idea is that while we are going over this slide, that you take the time to complete the questionnaire. We want to be able to give you the pool of what people are thinking, what topics that you want to hear, what you think about today's topic, and what your questions might be on implementation science. Dr. Chambers is going to take time to answer a lot of the questions that you may include in that pool. So if there are questions you have, this is the one way you can ask them and make sure that that is responded to. So you can let me know when you're ready. Can you share this slide? Okay, coming up. This is not the slide I sent to you. Can you share the one I sent to you, please? Please, can you take this down and share the slide I sent to you, please? Sorry about that. So while Ikenna is trying to share the slide, if you can go take a look at the link. I think you can also, Sonia, if we can put the link again, just in case people are joining. Because I think if the link was put in before they join, they might not see it. So I think Tavos, if you can put the
Yes, Prof. I think the links are in the chats. If folks can use the links in the chats, just click on it, use the link. It will take you to a web page where you can respond to some of the polls, some of the questions we had raised. I would appreciate this greatly.
Thank you. Thank you. Can you go back to the beginning of the slides? Okay, just one slide forward. So thank you so much. So the Nigerian Implementation Science Alliance was established in 2015 as a national collaborative to drive implementation science in Nigeria. That was the initial aim that we started this. It was a place for people who are researchers in universities who are focused on implementation science come together with people who are implementing programs using the principles and the frameworks and the strategies of implementation science, the policymakers who use this research evidence that come out from those research, and of course, the funding agency that support these researches to come together to really look at things, but from the perspective of the African context. A lot of the things, the frameworks, a lot of the implementation frameworks, a lot of the implementation strategies that we know of, most of them were developed outside of Africa. And one of the things that this started was the idea for us to localize a lot of those strategies, a lot of the frameworks in a way to provide context so that we can have a cross-sectional learning across all of us. We focus initially on making sure that there is equity, there's equity, there's sustainability, and there is contextual adaptation in all the projects that we do. Next slide, please. So the other thing that Nisa did at the beginning was to create a practice-based research network. The practice-based research network is anchored on Nigerian Implementation Science Alliance Model Innovation and Research Centers. These are 12 sites that are selected from each of the regions of the country. So 2 sites from each of the 6 regions of Nigeria that make up the 12 sites. The idea is that when Nisa does research, what you see when he says this research was done in Nigeria, you can actually see, sorry about the announcements, but you can see that this research were actually done from all the 6 regions of Nigeria, and it actually gives you some of the variations you can see by these zones, different zones and different regions of Nigeria. The thing that we want to be able to do is to be able to have this infrastructure, have these cohorts developed in this area, and allow individual researchers and their partners to be able to look at maternal child health, look at palliative care, look at cardiology, oncology, and neurology. One thing is to be able to, as we do research in these model sites, we can actually see things that work and be able to use those things from the region to scale it up in that region from the experience we learn. So you're not taking things that may not work in northern Nigeria to go and implement them in the south of Nigeria, but you actually have a site in south Nigeria that actually have implemented this, or you have a site that is in north central Nigeria that actually have implemented it successfully. So that as you scale up, you're actually going to know that what you're being scaled is something that's most likely to work. The other thing is that we wanted to facilitate collaboration among the community, the hospitals, and the teaching hospitals. All in all, there are 36 sites that make up the practice-based research network, including 10 teaching hospitals, 10 local hospitals, and 12 teaching hospitals, 12 community that we work in, and then 12 local hospitals that we wonder. Next slide. The Nisa conferences have been happening since 2015. We missed 1 year during the pandemic in 2020. So this year will be the 10th anniversary of the Nisa conference. This has been growing every year from year to year. The first conference we have has been 250 people that got together. The last conference last year was over 500 people. The team last year was driving change and everyday implementation, and we actually had people coming from 5 different continents for that conference. That was one of the first time we collaborated with the Global Implementation Society, and there are many of the Nisa supporting organization that works there. One of the things, again, we wanted to say great platform for you to share the programs and the research implementation you're carrying out, as well as the outcome from your projects. Next slide. The Nisa Research Week was something that we started because we wanted to focus on a way to provide didactics and also to pair a lot of the people who developed things like implementation frameworks with people who have used those implementation framework in the African setting. We focused on 2024, focused on the practical tools for designing and evaluating implementation projects. So we found something like Greg Aarons, who developed the EPIS framework, be able to pair them with someone in Africa who have used the EPIS framework in their work. Or you look at someone, talk about hybrid implementation designs, and look at somebody who have used such design in their work in African setting. This year is really a very important thing. What we want to do is to match, you see this everything. David Chamber today, again, is going to give us a broad overview of implementation science. But in each of the next days, tomorrow, we are going to talk about career development, the opportunities that exist for early careers, for mid-career, or for late career stage investigators, and what opportunity they still have in research. On Wednesday, we're going to talk about listening from the National Heart and Blood and Lung Institute at the NIH, talk about chronic diseases and implementation science in them. On Thursday, we're going to talk about implementation science in mental health. And on Friday, we're going to talk about implementation science in cancer control. Next slide. One important thing that I wanted to talk about here is the CITIA Scholar Program. This has become one of the popular programs that we have here. It is competitive. This year, we had 168 people apply for the 12 position that we have. This really is a 52 weeks hybrid and didactic mentoring program that focuses on both the technical skills in terms of how do you put a proposal together, but also in professional skills, like how do you manage a research team? How do you communicate science to the community, communicate science to the policymakers, and communicate science to your fellow investigators? Trainees has come from Nigeria, from Kenya, and other African countries. And in the success of that CITIA Scholar Program that started in 2022, we also did receive a funding from NIH that started with the Auto program. The Auto program was focused on enlarging what the CITIA Scholar initially was doing on technical skills to increase professional skill, recognizing that the professional skills is one of the things that make us lose leaders in research, especially coming from Africa. The Auto program supports programs in 4 countries, Nigeria, Kenya, Tanzania, and Zambia. We include, again, didactic, interactive lectures and assignment. We are hoping that will refine this curriculum, and that beyond funding, which is what this whole thing today is about, that beyond that particular funding, that the CITIA Scholar Program will continue irrespective of whether you receive funding to enlarge the number or not. What you would do if we have funding would be to increase the number, of course, the 12 to more number. But if not, that 12 that we start with, we can sustain that even beyond the funding. Next slide. I'm going to end here by just take a moment to say thank you to all the organization that has supported Nisa throughout these past 10 years. And just for a brief moment, I wanted to take a look at this slide, and this includes implementing partners. This includes academic institutions. You will see the popular ones you know here, whether it's APIN, AQ, CIHP, Caritas, Data FI, CCRN, and the Institute of Human Biology, or the Healthy Sunrise Foundation. Next slide, please. Again, this is another slide just to continue to say thank you for all of them. They are the ones that have done something that is remarkable. In 2015, when we started the NISA conferences, the conference fee was $100. In 2025, 10 years after, the conference fee is still $100. The reason we paid that cost was because it's subsidized by all these Nigerian organizations. So we have not relied on any funding. We are not funded. NISA is not funded by any particular organization. So it is what we call a value proposition. So people support it because they have benefited from it. So all these organizations, in addition to supporting that conference, bring their members to these conferences because they think they have gotten value from it all over these 10 years. And that's why they continue to do so. Next slide. When they put in those fundings, what those fundings are able to do is that they're able to pay for the hall, they're able to provide lunch. I remember meetings where they said we should remove the lunch and let people go and pay and get their lunch. After all, when I pay $800 to go to meetings abroad, I still have to get my own lunch. So people are saying, how can you provide lunch on the 3-day conference for $100? The lunch and the things we provided are not coming from those $100 because you won't do that. The lunch that we provide are coming from these sponsors that we have. And these sponsors, again, are organizations that bring their members to this and say, we are bringing our members to this because we think it's a value. For the cost of us sending one person to the US for a conference, we can bring 20 people to NISA conference. And that is an opportunity we're trying to grow and open up so that people in Africa can actually have a conference when they cannot go to the north part of the world, that they can actually attend a conference where we are able to bring the north part of the world to those conferences. Next slide. Thank you so much. I'm hoping that during this period, you have been able to complete that poll. And we'll turn it over to Cornelius to share the poll's result with us. Thank you, Cornelius.
Thank you so much, Prof, for for sharing this information. We think this is a fascinating work that you are doing. I am particularly intrigued by the fact that you mentioned it's been almost 10 years, excluding the year that you didn't have the conference. Since all this started, we think this is a good work you're doing, and how the project itself started, some of the challenges that you've experienced along the way, the help that you've received, the support that you've received from different partners, to the help that you've received to address these challenges, and your hope and aspirations for the future. These are very exciting, very remarkable information that you've shared with us, Prof. So I'll just find out now. Let me just turn over to the IT section if the results are out and if they can share the results. Can you please share the results, please? Is this Ikena who will do this? So while we are waiting for the results, I think I should probably just take you through some of the questions that we raised. We asked for you to identify one particular, word that describes you. So there we have options for you to select from, either as a researcher, implementation scientist, implementation practitioner, healthcare provider, policymaker, program manager, student, research administrator, CEO, or others. Then you specify. The second question we ask you is, what is your level of implementation science? No knowledge, basic knowledge, moderate knowledge, advanced knowledge, or an expert in the field? Then we also asked you to share with us what your level of knowledge of implementation research is. The options we have: none, beginner, intermediate, advanced, experts in the field. And I think there is one final, for the final question: how familiar are you with today's topic? Not familiar, slightly familiar, moderately familiar, very familiar, or an expert in the field? So it would be nice for us to see how you responded to these questions. So for the first question, what best describes you? So a significant number of people say they are researchers. About 7 people mentioned that they are implementation scientists. 3 people mentioned that they are implementation practitioner. 15 people say they are healthcare provider. Nobody selected policymaker. 5 said they are program managers. 4 said they are students. 5 say they are administrators or grant managers. And 2 selected CEO or institution head. And 2 said others. For the second question, what is your level of knowledge of implementation science? 9 mentioned say no knowledge. 23 say they have basic knowledge. 29 say they have moderate knowledge. 3 advanced knowledge, and 3 experts in the field. What is your level of knowledge of implementation research experience? 9 say they have none. 25 say they are beginners. 25 say they are, they are at the intermediate level. 5 mention advanced level, and 1 expert in the field. How familiar are you with today's topic? 10 say not familiar. 26 say slightly familiar. 21 say they are moderately familiar. 4 say they are very familiar, and 2 say they are experts in the field. Which of these words, I think we've seen this, right? Okay, which of these words best describes how you feel about today's topics? 27 say curious, 2 say confused, and 32 say they are excited. Oh, wow, that's fascinating. So Dr. Chambers, it's quite fascinating that while so many people claim that they don't have so much of experience, but yet there is some form of enthusiasm and excitement about the research topic itself. Do you want to start from this before you start your presentation, or you just want to dive deep?
Sure. I mean, happy just to say a couple of things. I mean, one of which is thank you, right? Thanks for everyone. We know how busy everybody is, and just the idea that you're taking time out of your busy schedules and the many different things that you do to join us is a wonderful thing. The idea that there's some familiarity and that there is maybe no skepticism of whether we should be here is actually a good sign. And so with curiosity, which I try and bring to this each day, with excitement, which I also try and bring, and some confusion because this is complex. It seems like we've got this really nice mix, both of people and of ways in which you're trying to engage with this material. So this is awesome. Did we have that other way to get questions from people? That was the one that I didn't quite see in the...
Oh, right. The one question about implementation science, right? Probably
maybe we could put that in the chat.
Well, okay, all right, yeah. We can put that in the chat and maybe bring it up while at some point during your presentation. Right.
All right. Yeah, I'll just and happy to mention it. When we had talked about setting up the session, the happiest place for me is where we have an opportunity to hear what questions you have, and to the extent possible, whether it's today or through the course of the week, answer as many of those questions as we can. You're going to hear me talking to you for a while, but so valuable for me is whatever dialogue we can have and whatever way we can make sure that we advance our own understanding and what we're challenged with. So that was why I knew initially we had some idea of trying to do some sort of a word cloud or some way of gathering these questions, but maybe, while as they come to you, if you want to just in the chat, put what is the most pressing question in your mind around this whole idea of implementation science in health and healthcare. So does that sound good as a...
Yeah, it does. So we will set up the pool now, and then we would show the result here.
Great. And so should I just take it from here?
Yeah, you can take it from there, and I would let you know once the pool is in.
Okay, great. And so just so folks know, when I share my screen, I won't have immediate access to what people are putting in the chat, and I won't be able to see, hopefully, some smiling faces or, interested or curious folks. But when we get to the end of the presentation, again, I'll be able to see the chat a bit more. So just bear with me.
I think this might be a good time to tell people where to put. They have a Q&A button. So if you can put your questions on the Q&A, because we are going to first of all answer those questions that are in the Q&A, it will be difficult to find questions in the chat because that chat goes very fast. So click on the Q&A button and we will go through one by one every question that is in that queue. Wherever the chamber can stop, whenever he stops, we will continue until your questions are answered if it is in the Q&A. So put it in the Q&A and we'll follow it according to order. Thank you so much.
Perfect. Thank you for that. Awesome. Okay. So with that said, I'm going to share my screen, and then what I also actually before I do, just want to say how amazing it is what you've all been able to accomplish through Nisa and through other activities over the last 10 years. I mean, I remember these early years when it really was about trying to broaden understanding and capacity, and there's so much that you've all been able to build. So it's just, again, a pleasure for me to join you again, having had a chance to connect with some of you in the past. Okay, so with that, I am going to share my screen, and then I am going to turn this into slides. So let me do that. Okay, just maybe since I can't see anything anymore, just verbally, do you see the main slide?
Yes, we can.
Okay, perfect. Okay, so what I wanted to do over the coming minutes, because we do have a range of different exposures to implementation science, understanding of, and engagement in implementation science, I thought I would provide a bit of a broad overview, not just about some of the things that we've been able to accomplish together as we've been trying to advance answers to these really important research questions, but also some of the challenges that linger, with the hope that we as a large community can really hold ourselves accountable for making sure that the answers to the questions that we provide are as meaningful and as beneficial as possible to people's health and healthcare. Because ultimately, the reason why many of us are here is because we have a fundamental belief that we can do better for all of those people who are along different journeys of health and of illness and wellness, and ways in which we can make sure that what they have access to and what they're able to benefit from is as universally helpful as possible. And so the way that I've organized the things that I want to talk about is first just a little bit of background sense making, how I think about implementation science and how it relates to health and healthcare, some of the key activities, resources, areas that we've really focused on, and then push us to think about what are some of the assumptions that we make about this whole area and about how our interventions, once developed, make their way to hopefully benefit people. And what then does that encourage us to think about and maybe think differently about when we're trying to do a better job of meeting the needs that people have around the country, around the region, around the globe. And then, as was said before, the rest of the time that we can spend for questions and discussions will be great. So I wanted to start out with just a way in which we've traditionally assumed that research is developed and the way in which we traditionally assume that the disease process happens. And what you'll see in both of these cases is, by and large, it's been this assumption that we progress linearly, that we create this idea. We come up with this idea that we think will ultimately have some benefit for people's health. And then we have a series of steps through which we advance that idea, and ideally it turns into a particular intervention. You then see the clinical development, where we have a phased approach by which we're often taking our interventions and trying to determine whether they're safe, whether they're efficacious, and whether they are feasibly able to be delivered in clinical, community, public health settings. But you'll notice that it often is this idea that we know everything that we need to know to progress to the next step, and we just proceed in the linear fashion. And I think we do have to ask ourselves whether that's an assumption that we should continue to make, whether all good ideas are going to come at this early end, or whether there's some way of thinking much more interactively about where we learn, where we pose our questions, and where we find our answers. Similarly, you see this from the NCI, the research continuum. We often talk about basic biology and then leading to implications for prevention, for detection and diagnosis, for treatment, and then ultimately for public health. But we have to ask ourselves similar questions as to, is the starting point always going to be in that basic terrain, or is there important research that we need to be continuing to do in our clinical, our community, our public health settings? So the implications to some degree of these linear models is that it takes an awful long time to turn an awful little of what we learn to benefit population health. And so this, which is now 25 years old, was a publication by Bayliss and Boren, where they charted out what happens if we complete our research and we see the publication as the way to best implement our findings. Well, so in the middle, what you see is that publication pathway. We complete our research, we submit it, we hope it's accepted, it gets published, it hopefully gets contained in various databases, and then becomes the input for our reviews, for our guidelines, for our textbooks, and then gets to implementation. What you see from this graphic is on the left side, there's a lot of ways in which we lose those valuable research findings. Maybe there's a study that didn't come out with a positive result, and so it can't be published. Maybe it's a small study, and so it doesn't get picked up as we are synthesizing the different evidence. The other thing that we see from here is that there are different time horizons associated with making it through this publication pathway. And while there's been some improvements in technology, the underlying amount of time it takes, if we rely solely on publications in journals to actually reach people in terms of the different interventions, is this factoid that it takes 17 years to turn about 14% of original research to the benefit of patient care. We should do better than this. And we have done better than this in certain occasions. But often we're still going back to the assumption that the publication will be the driver of everything that we want to accomplish in health and healthcare. A few years ago, we looked at this same question of how long it takes to get to a reasonable level of uptake for some of our cancer control interventions, me being at the National Cancer Institute. And what you can see is that across these 5 different types of cancer control interventions, on average, it still took about 15 years in order to get to substantial uptake. Now, I'll note at this point that what substantial uptake was in the Bayliss and Bourne article, and then in our work, was assuming that 50% of people then had access to these interventions. And I think relatively few of us would assume that that's full success, that we only get to a situation where someone is just as likely to get evidence-based care as they are not. That's not good enough. And yet we still know how long it takes even just to get to that point. So the point being is there's a lot of room for improvement, and it really takes all of us engaged today around the world to make sure that these statistics change, that we use far more of our research to inform the care that we provide, and we do so with greater efficiency than we have done in the past. Now, this process has enabled us to get to a lot of different evidence-based practices. So it's not to say that there haven't been significant successes. We at the NCI have as one resource an evidence-based cancer control programs website, which has up to 200 different interventions across different types of cancer control that have been packaged and are hopefully available for people wherever they are to integrate into their work. But we can certainly do better to make sure that those programs don't just sit on a website, but that they actually make their way to benefit as many people as possible. So let's assume if we have these evidence-based health interventions, that we're now engaged in trying to make them available. What are some of the issues that we come up with? Well, the evidence-based health intervention, the fact that it has evidence around it is great. But the value of that health intervention is really only going to be so good as how and whether it's adopted within our different systems, our communities, our clinical settings. But not just that, right? Whether we have providers who are in a position and are trained to be able to deliver those interventions. And of course, not just that, right? We can have provider training, but if we're not enabling those providers to incorporate it and to choose to deliver that within their practice, then how good is that? And also, we can have trained providers, but if we're not able to get it to people who would benefit from those interventions, then what is the value that we're going to have? Now, again, with that 50% threshold, if we got half the way there in terms of adoption within our systems and provider training and those trained providers being able to incorporate it into practice and getting maybe to half of the people who might benefit from it, which is helpful, even if we discount all of these other challenges that we know exist around access, around adherence, around dosage, around maintenance, we realize that that evidence-based health intervention is now down to a fraction of the benefit that we thought we were going to have when we completed our trials, we published our results, and we said, hey, this intervention is ready to be used. So these are the types of things, the types of challenges that we, thinking about implementation science, have to be able to address and have to do well, not just at this 50% threshold, but ideally for everybody, optimally, so that everybody who could benefit from an intervention is getting there. Some folks may be familiar with REAIM as an evaluation framework. What REAIM says is that while we've made progress, distinguishing between the efficacy of an intervention in very pristine settings and the effectiveness of that intervention within a diverse set of different settings and populations. We absolutely need to make sure that we're asking these other questions. How well we're reaching the targeted population that could benefit from an intervention, and then again, the adoption, the institutional support that we want to try and foster, the ways, the process through which we implement a given intervention. And then increasingly important, and I know something that's been instrumental in Nisa's work over time, how well we're maintaining or sustaining these interventions. It's not great to devote all of our energy to, can we get something to be delivered on day one if it's not going to be sustained over time? So again, made a lot of progress in recognizing that real world testing of our interventions is important. But if we don't crack these really key questions, then we're never going to do justice to the populations that we're trying to help. And now, if we take a specific intervention like a cancer screening modality, we recognize that having that modality, being able to have tests that could determine whether somebody has cancer or is at high risk for cancer, et cetera, is good. But we need to turn our attention from the what is that intervention to the how do we make that intervention a reality as it's implemented in different settings. And these are some of the implementation science challenges on the right that we have. Is screening a priority in the settings in which these tests might be delivered? What are the processes through which we reach all patients who could benefit? What are the fit of the interventions with the different workflow within practices or communities, the fit of the interventions with the populations and whether they are able to participate in them? How do we think about implementing these different tests in varied models of care, in varied practices? What sort of follow-up? It's not enough to screen if we have no follow-up for what happens if somebody requires more care. And then what are the workforce capacity and training needs that may be there if we want to make cancer screening, evidence-based cancer screening, a reality? It's also really important along that point about follow-up to really look at what is the intervention that we're trying to implement. Is it, in this case, just the screening test? Does it include the information dissemination? What happens with the results of that test? Does it go beyond that and think about enhanced monitoring or follow-up that's needed after that screening results are received? Is it preventive care? Is it treatment? Is it survivorship care for somebody who is diagnosed with and undergoing cancer treatment? Is it all of the above? Too often when we think about implementation, we're setting more narrowly what is the intervention that we're implementing, and we're making a lot of assumptions about what else may already be in place. Really important for us to think about what is that intervention and what is the broader pattern of care or pathway of care that it's going into. I know many of you know this very well, but it's just sometimes when we think about asking the question about implementation, we ask it very narrowly. And so the encouragement is for us to think more broadly about what does this fit into. At the same time, we also have to make sure that we're not assuming that our interventions work perfectly for all those who might be looking to deliver them or looking to receive them. Too often it ends up with what you can call the fish bicycle conundrum. There was an Australian grad student in the 70s who said, and I'll paraphrase, "A blank needs a blank like a fish needs a bicycle." You can fill in the blanks as you like. The point being, too often we assume that that intervention is already perfectly designed to be delivered in a particular setting or received by a particular population. And if we don't test whether that intervention is like a bicycle and the person or the setting is like a fish, then we're not going to do very well at ensuring that our evidence base is meaningful and is feasible and acceptable. These are the kinds of implementation outcomes that we'll do well to keep an eye on. So I do at this point, because there may be some confusion as to how we think about some of these terms, like to put out the definitions for how we at the NCI and those at the NIH have been thinking about implementation science and the related dissemination and implementation research. Implementation science is the name of our team at the NCI, and it's really this broader concept of how we study different methods to ensure that our research findings, our evidence-based interventions are integrated within various healthcare policy and practice settings. At the NIH, we have for a long time talked about D&I research coming from two different challenges that we historically as a research community haven't done as good a job as we would like. This notion of how we disseminate our findings, making sure that we're studying and we're developing better processes through which we distribute information, evidence, intervention materials to different audiences so that we can spread and sustain the knowledge that's related to the evidence base of our interventions. We contrasted that from implementation research, the idea that we're developing, we're testing strategies to adopt and integrate our interventions into different settings so that we're able to reach more people and improve more outcomes than if it was just one person at a time, so that we can really see population health benefit. Now, when we study implementation, we like to draw a contrast, and I mentioned this briefly before, between the what and the how. The what is the intervention that we're trying to deliver, and how do we get that intervention to be delivered? So the typical clinical trial that we have would basically go on the outside of this picture, right? It would start with a what. It would start with an intervention. We would test that against some comparison, and we would then be measuring all the way on the right whether we improved health outcomes, symptoms, functioning, satisfaction, disease process, etc. But what we notice is that if we just focus on the left and the right, we jump over this really important question of how, right? What are the implementation strategies that we need to design and test so that we do better with implementation? We end up with interventions that are more feasibly delivered, that penetrate as far through the system as they can be beneficial, that are sustained over time, where we understand what the costs are that are associated with delivering that intervention. The argument here is that if we don't jump over the how question, then it enables us to improve implementation outcomes, which then has a knock-on benefit to our service systems. And then that, at a much larger scale, improves the health outcomes that we started trying to influence, trying to benefit, and should end up with. So the idea of studying implementation is to shift from that usual to this core of implementation research, but with an eye that we're not successful until we cascade outward to really improve health outcomes. We have seen over the last 10, 15 years, a lot of development in categorizing and testing our different implementation strategies. Credit Byron Powell, Tom Waltz, and others for identifying buckets of these different approaches to the how question, to trying to integrate our interventions, test them, and add to our evidence base for how we do a better job with adoption, with implementation and sustainment. And so we're not at a point when we have to make this up necessarily from scratch, but we can really advance upon the work that's been done to test different strategies, audit and feedback, adaptation, providing technical assistance, thinking about ways in which we can finance our different interventions. So this is all progress that we've been able to make over the last number of years through a lot of people's hard work. We've also set up to a much more nuanced and advanced understanding, not just that we throw as many different strategies at a problem as possible, but we really think more mechanistically. We want to answer the questions of how and why our implementation strategies work. And huge credit to Kara Lewis, who you'll be hearing from later this week, and others, for really advancing our understanding so that we're much more precisely understanding how and why these different strategies work. So credit to her and team for helping to unlock a much more advanced understanding of how things work and when they don't work, so that we don't feel like we're, again, starting from scratch each time. Huge credit also, and certainly Nisa is part of this, for the immense efforts to try and make sure that there's more training available to investigators, to clinicians, to practitioners, to administrators, to patients and families around implementation science or dissemination and implementation research. And so it's been really great to see how this next generation has been trained through all sorts of materials, including those that we've tried to make as available as possible to anybody who wants them. So what you see in front of you is the Training Institute for Dissemination and Implementation Research in Cancer open access version. This is a course that we did, that we adapted from a prior course that we had done across the NIH, across all of health. We adapted it specifically to cancer. And what we've tried to do is make sure that all of the materials that we've created as part of this course are available to anybody. So if you haven't seen this and feel like you might benefit, it's a modularized way to dig in a little bit deeper into some of these concepts that I've already mentioned. And hopefully it's resources that can help you as you're thinking about the most important questions that you want to try and answer. We've also benefited greatly from some of our investigators around the world who have been willing to share the applications that they proposed in order to conduct some really wonderful research. And so we still have a resource available for somebody to look at. What did that grant, how was that grant written? What types of frameworks did they use? What types of measures did they use? And then these folks have been gracious in being willing to answer questions as they come up around the different studies, and even just what it's like to propose and then to conduct this kind of research. We've also really been trying to encourage, and it would be great to see what thoughts you have about this, is that we don't just create a new context or start fresh with each and every study that we want to do or question that we want to ask, but really thinking about the equivalent of our laboratories. They're not laboratories in the traditional sense, but the places in which we're learning about implementation science are far more likely to be the learning healthcare or learning community systems that hopefully many of us already engage in. The idea is that we need to learn as much as possible of that practice-based evidence, which will inform both what's going well in implementation and where might we need to improve things. And so really for each of us to think about what is the landscape in which we're conducting or receiving intervention, delivering interventions or receiving interventions. What are the most important questions that are coming from these partnerships? And do we have some of the infrastructure to be able to make the studies of implementation coexist with the delivery of the different interventions? So the hope is that over time, we do a better job of taking advantage of so much knowledge that is gained through practice, through policy, through community efforts. Just to advance to what we've been able to see created in recent years, there are a number of other resources that hopefully people have or may take advantage of. We've had different guides to implementation science for practitioners. We've had different webinars that have been archived and are available. We've had specific white papers to try and focus on methods in implementation science that hopefully are helpful. I mentioned the Evidence-Based Cancer Control Program's website. And then, for those who've been able to join us in Washington, in the Washington, D.C. area each year, we continue to have our annual conference on the science of dissemination, implementation, and health. But for those who are not able to access that, each year we do publish the proceedings in the journal Implementation Science. So even if you're not able to join us, if you're interested in understanding what are the types of studies that are presented there, most of what we deliver in terms of content at that conference is available to folks. We've also in recent years tried to think about other ways of bringing partnerships together. And so we, in the cancer space, developed a consortium for cancer implementation science back in 2019, operated virtually. We're looking forward to getting people back together in person again. It has a series of different action groups, and you'll see those on the right. These are some of our current action groups. There have been inactive groups because as the field has changed, newer priority areas have emerged. And in some cases, people have felt that maybe there isn't as much of a need to just focus on a particular topic in isolation of other things. And so this consortium has really been predicated on the idea of how do we make it easier for more of us to engage in studying implementation in the cancer space. And frankly, a lot of the work that we have discussed as part of this consortium isn't just cancer specific, but really extends outward to other areas of health and healthcare. So if you are interested, we would love to engage you more in follow-up conversations, because as you see, one of the action groups has been from the beginning, implementation science in global health, and how do we advance that together. I would also like to say at this point that even if you don't see yourself solely in that purple circle conducting dissemination and implementation studies, for those of you who reported that you're researchers, you might see yourselves earlier in this process of developing and testing interventions. we'd hope that you might consider these issues of how we disseminate our evidence, how we implement our interventions earlier and earlier. And so certainly the degree to which we can start thinking about who's in a position to deliver our interventions, what's the fit not just with the population within our studies, but the larger population that we're trying to support. And then how along the way can we build in more tests of training, of support, adherence, mediators, and moderators to how we deliver our interventions with high quality. Etche had mentioned previously that in past years we've focused on hybrid designs, and certainly that's a way where we can combine these questions about what is my intervention and how well does it work with how do I get that intervention to be implemented. And so we have more tools and more thoughts than we did before about how do we not wait until the end to think about implementation. And at the same time, I think we still have a challenge in which a lot of well-meaning efforts in how we design our studies can ultimately exacerbate issues of reproducibility or issues where the findings don't generalize to the populations that we're trying to support. And so as we design any study, thinking about how we choose the sites that we're working with, how we think about who is able to be part of the study or who might be excluded, how we think about the level of information technology or practice infrastructure or the types of outcomes that we focus on, the organizational context and climate, and even the broader ecology in which our care is delivered can inadvertently make it less likely to be applicable, to be feasible for other sites to deliver. And so the more that we can design our studies, think about context as broadly as possible, the better off we may be with the studies that we're able to support. At the same time, I see that you all represent lots of different disciplines, lots of different roles. And really, we see that implementation science is around leveraging so much of the expertise that you bring in your daily lives, so much that partners bring toward trying to think about how do we better conduct our research? How do we understand theory? How do we think about designing our studies in a more helpful way? How do we choose the right outcomes? And so just an encouragement to say that whoever you represent or however you define yourself, I hope that you see that there is a carpet rolled out to welcome you into this work, because without your participation, we're not going to get very far. And similarly, we can't just think about our favorite intervention and getting everybody to use it. The more that we can think about how we bundle multiple interventions together, and certainly a lot of you have done this so well, or blend our different interventions so they touch on different risk factors and different diseases, the better off we'll be. So while we've created a lot of different evidence-based interventions, we haven't always thought about the most efficient way to bring them to people. And you have, I'm sure, lots of great examples of how you've integrated different interventions. The more that we can study this and think about what the right approaches are to bring different interventions together, we'll be better off. At the same time, we also know that there's been great advances in information technology, and digital health is a subset of that. And at the same time, some of our studies have been developed almost in isolation of all of these different advances. This particular picture comes from one of my favorite slides, Bill Riley, who used to be at the NCI and at the NIH, talking about if you were back in 2005 and you were creating the most technologically advanced intervention and you were studying that, usually once you decide on your protocol, you kind of freeze it and you hope that the world doesn't change. But over that span, we can see at the top all of these different ways that technology changed just over the period in which this one study might have been funded. And of course, we see so many more advances that have happened. And so we really need to think dynamically and about how technology is influencing the way we're interacting and the way that we're receiving care if we're going to do better. Context is changing, and so do our needs and the strategies that we need to employ to overcome them. So where I want to shift to the rest of the talk is really encouraging us to continue to think a bit more dynamically, right? A lot is changing, as you saw from that technology space. And so what I would usually do, but I can't see you right now, but we'll sort of do it and we'll guess how many hands are being raised. I would usually ask you, how many of you believe in the following assumptions? That our evidence-based interventions or evidence-based practices are static. Once they've been developed, they should freeze forever. How many of you believe sort of similarly that our systems are static? Once we've seen our communities or our systems, they will never change. They'll always be the same. How many of you believe that implementation is going to always proceed, that one practice, that one test, that one intervention at a time? How many of you believe that our consumers, our patients, homogeneous, all the same, one size fits all? And how many of you believe that the only reason why somebody is not implementing one of our evidence-based interventions is because they're being hopelessly irrational? Now, while I can't see you physically, I can intuit that very few hands went up when I asked each of those 5 questions. And yet, so much of our implementation research still adheres to these kind of assumptions, that we start with our interventions and we say, please don't change them. That we start with our systems and we hope that those don't change over time. We really usually do one study, one intervention at a time. We're assuming evidence-based means everyone will benefit, and we're going after 100% uptake, meaning we're not thinking about other reasons why we should not implement our interventions. And so I mention these because there are some associated processes that we reify, that we validate over and over again if we adhere to them. And the first one is this notion of voltage drop. And that basically says that we fully assume that as we move from an early efficacy study to an effectiveness trial and then into our dissemination and implementation studies, that we expect that our intervention will not do as well at each stage, that there will be this voltage drop. And there are reasons for this. It's more complicated. We're not as sure that this intervention is going to work as well under heterogeneous circumstances. But we do have to ask the question as to whether it is to our advantage to continue to believe this. Does it set us up to expect less and less of our interventions as they move along and be content with an okay intervention at the end of it? Similarly, program drift, the idea here is that we fully expect that the best the intervention will ever do is in that initial stage of implementation. We've trained everybody, everybody's motivated, ready to go, excited, not as confused. But over time, what happens is that we deviate from the way in which the intervention should be delivered, and we assume that that's going to mean that the effect is going to decrease. Again, we have to ask whether this is beneficial. Is it beneficial for us to assume that deviation will mean bad things happen? Now, I'll give you another example of deviation. And as Cornell had mentioned, I do love music and I do try and play guitar. I recently saw a movie of Bob Dylan's early years. And I remember hearing the first time his song Knocking on Heaven's Door. Now, I'll note that I did not hear Bob Dylan's version until much later because there are so many different versions of this song. Now, I mention that because I happen to like a number of these other versions that you see on the right versus the original intervention, the original song. And maybe some of you have different preferences. If we only assume that there is one way to deliver an intervention, then we're ruling out all of those potential improvements that will come. And we're not thinking about the variable use of our interventions for different population settings and purposes. We need to do a much better job of understanding and learning from adaptation, because as I would argue, this being an example, we can improve things over time if we permit and we support thoughtful adaptation of our interventions. Now, we know that adaptation is happening. There are all sorts of reasons why our interventions need to be adapted. There might be customizations to our service settings, better fit with our audience, ways in which we're delivering our interventions, cultural adaptations. We assume that there may be some core ingredients, but there's an awful lot of sources of intervention adaptation. And so if we don't take those on, then we're really limiting the evidence base and limiting who can benefit from our interventions. In short, we're so afraid of this program drift idea that we miss out on all of these ways where we might actually see what some would term positive deviance, of ways that our interventions have improved over time. We can learn from them and actually strengthen the evidence for our interventions over time. A lot of this is about embracing dynamism, of not fearing and trying to rule out change, but embracing it and trying to understand it. And similarly, I would say we have that challenge with sustainability, where we often assume that sustainability is the act of preserving the initial intervention for as long as possible versus assuming evolution. So now, just out of curiosity, if anyone wants to type in the chat, and I can't see this, but I know my fellow colleagues can potentially call out if you can tell me what this is a picture of. So right here on the left side, a cartoon from 1963 to 1970. By typing in the chat, does anybody recognize or know what this is a picture of? These cartoons, and I'll just see if you can, if anyone wants to just share what's in the chat, that'd be great.
So do you want me to share some of the responses?
Yeah, very curious. Yeah, what are you seeing?
So I'm seeing Beatles, for example, hippies, musical group.
Yeah.
So far, those are probably the three responses, I think, top responses, but we're still waiting for others to.
Yeah, no, that's great. Okay, so just dealing with that.
So there's another one, John Lennon, someone said.
Someone said John Lennon?
Yeah.
Okay. Yeah, so cutting to the reveal, John Lennon is all the way on the left, and then you see Paul McCartney, George Harrison, and Ringo Starr, I believe in actually almost in that order. Let's see, it's John and then George and then Paul and Ringo, I believe. Yes, these are the Beatles. And the reason why I put up this particular picture is because it's very clear visually, even from this vague cartoon, that the Beatles' appearance changed over time. For me, as a music lover and having been raised on the Beatles years back, I know that their sound changed over time. And my personal opinion is that was a good thing, that evolution of their sound, of their experience was a good thing. And so if we take that on and apply it to our interventions, then we have to ask whether our existing interventions should be sustained forever in the same form that we've created them. If not, then we really need to be thinking about how we plan within our community and clinical settings for the dynamism, for evolution over time, and where we go from here. By the way, if you want to see that cartoon, that's the site of it. It's the evolution of the Beatles' hair. So well done guessing. All answers, I think, were right in different ways. For me, this says that we should expect dynamism over time. And if we're thinking about sustainability, which we see as a really important research endeavor going forward, then maybe it's less about trying to move the world around our interventions, but rather think about the fit between our interventions and the settings in which we are trying to deliver them. And then maybe over time, and you see if you go around the horn, the idea is that we can improve the quality of our interventions. We can think about adapting our interventions while our contexts are changing. And maybe rather than moving everything around that puzzle piece, let's assume that that puzzle piece of the intervention is changing, and that change is at the center of what we are trying to accomplish. Now, another area in which we've seen evolution is in the development and design of different cars. These are Toyota Camrys from 1983 to 2025. I put this picture up because that top left version was the first car that I remembered driving with my mom in. She had this 1983 Toyota Camry. And I only put this up because I think what you can see is there are many different ways in which evolution is likely to happen, and that we shouldn't be assuming that first picture or that first version that we see is going to be the best one going forward, particularly as we think about scale up. So now, scale up ends up being a really important area. How do we make sure that we're not just getting local benefit from our interventions, but that ideally we're scaling them up as far and wide as they can be beneficial? So again, some of the same questions that we started with, we want to continue to think about. What intervention are we trying to scale up? Now, when I was growing up in the 80s, I was confronted with what then was the premier sort of intervention or the state of the art in a given area. This is what I might be looking at. Again, just to see in the chat, any thoughts about what they're looking at when they see this screenshot? Does anybody recognize what this might be? And I'm going to rely on my colleagues to call out any responses that people put in.
So I'm just waiting for their responses, then I can read them out to you.
Perfect.
To David, yeah.
So somebody says video assisted referee VAR.
Video assisted, what was that?
Referee VAR.
Okay. And any
video
other
game.
Okay, video game, right.
game.
Yeah, video game. Does anyone know what
Football
this is?
pitch. Football game.
Ah, well done. Well done, folks. Okay, I might not look at this immediately and see that this is a football game. However, if I fast forwarded a few years, I might see this particular version and better recognize that this is football. You can see the goals, you can see the players, you can actually see the ball look less like a dot and more like a little soccer ball moving around. And so what we can see again is over time, things are evolving. And many of us, as we're going through our lives, are exposed to these different interventions, so to speak. And so it forms, what are we demanding? And so I think the question that we have to ask is, if we're on the left side trying to scale up this thing on the left, this early version, and something comes up on the right, how successful are we going to be if there's a mismatch between what people might be expecting, that thing on the right, and what we're delivering on the left? Now let's fast forward even more. I have a son who is a soccer player. Oh, and somehow the slide disappeared. So I can't even show you this, but if you look at what video soccer looks like right now, it's like watching a live game. It's that much better than it was in the past. And so apologies that somehow my slide disappeared, but if you look at the photorealistic version of this same type of intervention, then you would also have to ask, outside of some nostalgic idea, is anybody wanting these things anymore? Similarly, we need to be thinking about where we're scaling things up. And you know far better than I that many interventions are created with one particular level of resources and type of setting in mind, and that yet we know that there's so much variation in where people are seeking care. Similarly, so many of our interventions are created within urban settings, and that we know that there's a lot of populations that are more dispersed. And the scale up of interventions in these different settings may look very differently. Now, at the same time, we don't want to assume that we're just adding more and more interventions into really, really constrained systems with resources. And so there is a need for us to understand de-implementation. Are there ways in which some of our interventions may not be as useful or may need to be replaced by other interventions so that we can better meet the needs of people who are seeking health and seeking healthcare? And so Wynn Norton from my team and several of us tried to think about the nuances of what it means to stop delivering an intervention, or to restrict its use only in certain cases, or to reduce the level of its use overall to replace it with something else. And so this is a really important part of implementation science, to think about what should no longer be delivered or what is less helpful than other things. Now, I want to end with a couple of things. I started out with this idea of 17 years, 14% of original research to ultimately only reach about half of the people we want to. There are people who have been really thinking about how we accelerate the translation of our work. And you see some of the building blocks are in the wonderful partnerships that you've all been able to develop, to cultivate, to represent. It is in some of the ways in which we've designed our interventions so they're more likely to meet the needs of people. And I think it is in the way of our learning systems that we're expecting that every opportunity where we see somebody is a chance to learn something about our systems, about the care that we're delivering, about how we better implement. And so our thought is that over time, we can pick up the pace if we're applying what we do know about partnerships, about design, and about the way in which our systems can provide that evidence that we should do better. We've also tried to think about some of the reasons why we can improve the speed that we're translating our interventions for use in practice and policy, and also some of the things that should be inhibiting that progress. So we want to make speed not just this frustration, but a target. And it's not to say that faster is always better, but to more critically say, can we more rapidly advance implementation, sustainment, and scale up? Or are there some cases in which we really need to move slower? This all is about the hope that hopefully we can all embrace in the future, where we can take more precise ways of trying to support people's health and healthcare within learning systems with implementation science, so that we learn as much as possible about how we're delivering these interventions optimally. Where I want to finally finish is engaging you in what I see as this ultimate goal of our work, that idea that we can embrace this big tent so that all of us will find a home and will find space to work together, to collaborate around these issues of adoption, implementation, sustainment, de-implementation, adaptation, et cetera. So Karen Emmons and I last year put forth just a series of observations that we hope will help us going forward to establish this big tent where we can all participate in this really important work. First observation being that implementation science shouldn't just be about how we identify ourselves or what terms we use, but more importantly, should be about coming together around what are the key questions that we need to ask and answer, and what are the best ways that we can go to answer that. There have been times where somebody would say, well, I don't feel like I have a card that says that I'm an implementation scientist. Maybe I'm not welcome at this table. The hope is that anybody who is in a position to ask these really important questions and help to answer them will see themselves as being fully able to hang out under our tent. Second observation is that implementation science is itself a sort of hybrid or a collection of really valuable insights from science, from policy, from practice, from community, and really leverages those contributions. So at times there's questions about, is this implementation science or is this something else? Our goal is to move beyond that and to say, again, what are the questions and what are the wide variety of tools and of literatures and of experiences that can help us to best answer those questions? How do we leverage those contributions? It's not, us or them or you or me. It's about we together and valuing those different contributions. A third observation is really just that the capacity building that you are all doing, the support that you're all delivering, is something that we need to make sure is available for all partners, for people at all stages of their exploration of implementation science. And so while we've done a lot at the early end, the introductory training, the more that we can support people from the beginning until the end of their careers, the better off we will do. And that the ecosystem that we envision, that tent really does include and central to it are the partnerships within clinical and community settings so that we can scale up what we ask and what we learn. And so we want to make sure that we have as deep connections as we possibly can, as deep partnerships within all the settings where care is delivered, to be able to make sure we're asking the right things and we're answering them well. And going hand in hand with that is that who should be at the center of all of these investigations? Well, it has to be our patients. It has to be our families. It has to be our practitioners, our policymakers, who are putting into practice the very things that we're trying to discover, that we're trying to apply. And so there is no value, in my opinion, of trying to create a whole set of scientific objectives without thinking about who matters most. And of course, these are the folks who ultimately matter most. The goal, again, is that the bigger that we can make this tent, the more collaboration, harmonization that we can find under it, the more knowledge we can develop, synthesize, and then apply for all of our benefits. So just that last thought is that these are some of the things that resonate with me, the impact that we're trying to make with our work, the relevance that it has to our clinicians, our communities, our patients, our families, the timeliness, how efficiently we can answer these questions, how rigorously we can ask them and answer them, how we integrate our different knowledge, and how it generalizes as possible to all folks, are the kinds of things that at least may be useful in exploring for each of our work going forward. So with that, I know you've listened to me for a while. Thank you for your attention. We have a while longer to be able to engage. So I just want to say thank you. This is my email with a 001. This is my phone number if anyone wants to follow up. And I would love to have all opportunities to connect with you. Thanks so much. So I'm going to stop there, stop sharing, and then look forward to the conversation.
Thank you. Thank you so much, David. We have a couple of questions for you. Thank you for your amazing talk. Really, really great and a lot of information. So a lot of questions are coming in.
Great.
So someone is asking, and thank you, Dr. Balogun, Professor Balogun, for this question. Who executes implementation science and who executes implementation research. So, you put up the slide that talked about the difference between implementation research, implementation science. So who does what?
Yeah, and I know that some people make a stronger distinction between implementation science and implementation research than I may be making. There's a slide that I didn't use that has a Venn diagram where I see implementation research as part of, as I mentioned quickly, dissemination and implementation research, which we think about at the NIH, which fits in this larger terrain of implementation science. So first thing is I don't see a huge distinction between who's engaging in implementation science from implementation research. To me, it's the same group of people. And who are those people? Well, to me, it's a sort of multidisciplinary and multi sort of sectoral group. Because as I said, it's really important that the people who have experience within the settings that we're working are at the table in making sure that the strategies that we're trying for different interventions are as relevant as possible. It's really important to make sure that we have a notion as to what are the key outcomes that decision makers ultimately are thinking about when they're making decisions as to whether we keep these interventions being delivered. And so in some cases, that may be the patient making a decision. It may be the clinician choosing, am I able to deliver this practice? It may be an administrator who's saying, can we support the delivery of this intervention? On the science side, it's a range of different folks. It's people who are thinking about what are the methods that make sure that I can answer this question as helpfully as possible. It's, what are the theories and frameworks that help make sure that I'm not starting from scratch, but I'm able to build upon what prior work has done. I would stop from saying that it is only people who would identify themselves as implementation scientists, because I think it's a much bigger group. But it really depends so much on what's the question that you're trying to answer, and then establishing that team. It's really a team of scientists and of key partners together to try and make sure we can answer it. I hope that's at least a reasonable response.
Okay. So there's another question from Victor, and he's thanking you for your presentation and says, what strategies can be employed to effectively engage stakeholders in the development and implementation of new healthcare interventions, ensuring their needs and concerns are addressed and their support is sustained throughout the duration of the project?
Yeah, thanks, Victor. It's a wonderful question, and what I would do is call people's attention to engagement science. So there are a lot of people who have really been studying the different ways to try and engage key partners throughout the life of the research and even into trying to inform practice. And one of my colleagues, Aubrey Villalobos, from our team at the NCI, had led this effort of folks to review and do an analysis of the types of studies that we were funding in implementation science and what kinds of engagement approaches that they've used. So what I would encourage you to do is there are some resources around engagement science as well as team science that might be very helpful in some of those specific strategies. And so a great example, or great question. And I think there's been a lot of folks who have really pioneered the different approaches, whether it is about, partnership building, or whether it is about user-centered design, that kind of thing, model building, that kind of thing. Yeah.
Okay. So the next question is from Bartholomew. He's saying, what is responsible for the gaps between research findings and their practical application? Does this trend happen in the global north? Does developed countries? And how can we bridge this gap?
Wonderful question. So there's so many, unfortunately, there's so many gaps between the research findings and its practical application. I'll just put a spotlight on a couple of them. So I think the first one, again, and some of these go back to the assumptions that I was making. I think the first one is that we have an assumption that there is at times a single way in which we should develop and we should test our interventions. And by doing so, we have less confidence that that intervention is applicable to different populations and can feasibly be delivered in those different populations. So I think there's a whole set of barriers that are related to are we designing our interventions in a way that they can best be used? There's a lot of variations in resources, and similarly, there are a lot of assumptions that are made about what level of resources are needed within a setting to be able to deliver a given intervention. Sometimes that may be an assumption that there are information technology systems that are able to track progress on a particular intervention, or there may be availability of certain technologies that people can use to deliver an intervention, and that may be a limitation. There's also, I think, a variation in terms of what the biggest priority is for an individual or for a practitioner or for a system, and what type of care they need to prioritize. And so if I come in to a particular practice and I say, I've been studying depression, really important issue, and I want you to consider delivering this intervention to your patients. Well, that makes sense if that person sees the top priority is depression, or one of those top priorities, but there may be other more pressing needs. And that's why sometimes in isolation, an intervention may not seem to be as helpful as we would like it to be, because it doesn't match the needs of somebody. So those are just 3 examples, but there's a lot of reasons why it happens. And I think that's why this community is so exciting to me, because we can come together and say, how do we prioritize among those different challenges and overcome them?
Okay, so there's a question from Deborah. She's saying, thank you for the talk. And are there any healthcare practices that have been successfully reduced or eliminated through de-implementation?
Yeah, it's a great It's a great question. One of the things that you might, if you haven't taken a look at in the past, I would say 10 or so years, there's been these international efforts around choosing wisely. And I think what choosing wisely has done is posted a lot of areas where it seems like practice has not been as consistent with what we would know the evidence base to suggest. And I think a lot of those have been targets for de-implementation. In some cases, for us, it's been around over-prescribing of certain medications or over-screening. In the cancer space, we have evolving guidelines around the harms versus the benefits of screening. And so what we might find is, for certain populations, the advantage of getting screened, let's say, depending on what somebody's age is or the likely level of risk, may affect how much of a screening test should be used. And so those are examples where you have over-prescribing, over-diagnosis, over-screening, and then there are many others, but hopefully that helps. And so in a number of cases, we have funded a few different studies on de-implementation of some of those types of interventions.
Okay. So Dede is saying that there are so many implementation science models. So how do you choose the right one? And he's right. There's so many frameworks, so many theories, so many, yeah.
Yeah. How do you choose the right one of hundreds of these different models? It's such a good question. I think for me, there's so much common ground among these different models. So I would say one thing is, if there is a specific model that grabs you, that you feel like is most of the way there, start there. I don't think that some models may have more available resources around how do we measure each of the different components within the model. And so I know, as an example, the Consolidated Framework for Implementation Research, or the EPIS model that Etche had mentioned before, there's been a lot of efforts to try and map what are the appropriate measures to be able to use those models. And there hasn't been that case for all of these different models. Another thing that you might want to take a look at, there's a website called dissemination-implementation.org. Which I think I can type into the chat as I'm speaking, dissemination-implementation.org. Okay, so that particular, if you put if you make it a link, but if you type that into whatever search engine, that helps to allow you to look at, are we talking about, the organizational level? Are we talking about individuals? Are we talking more about dissemination versus implementation? Those kind of things, that helpfully shares what kinds of models are more relevant to what you're looking for.
Okay, thank you so much for that link. We're about to answer. You have a couple of more questions, but Cornell is going to go through them. We're starting with the question from John Bosco. So Cornell, over to you. Let's answer John Bosco's question.
Thank you so much, Prof. So I'm trying to locate John Bosco's question.
It's right at the top. It's right at the top.
Okay, yeah. So I can see the question now. Thank you. John Bosco is asking, it is intriguing to hear you talk about practice-based evidence. Is that it? How is this related to evidence-based practice, and how do we promote practice-based evidence?
Yeah, it's a great question. I do reference practice-based evidence, and there was a commentary a number of years ago by Larry Green, who I had the fortune of working with, that talked about how, in addition to evidence-based practice, we need more practice-based evidence. Ultimately, I think it's about trying to capture all available evidence to inform how we can support health and healthcare. But practice-based evidence typically is about saying that we have local experiences within our communities or our clinical settings where being able to observe what is happening within those settings and being able to determine what's working well and what might not be working so well could be very advantageous to our overall desire to learn and then to apply what we know. And so the idea of practice-based evidence is of saying, what are there data that we're already capturing? Is there information that we're already learning within our practice settings? And then how do we make sure that we're sharing that with our larger community? So I think practice-based evidence in part is about, what information are we already gathering, and how do we maximize the value of that? And are there key questions that we have that the best way to try and learn about them is by actually asking them in the context of our existing practice? So there's some people will talk about practice epidemiology, clinical epidemiology, as one way that we're capturing these kind of patterns in care. But I think it's all part of this philosophy that in order to learn from all evidence, we need to make sure that the evidence is generated from everywhere where we want to learn it. So John Bosco, I hope that's helpful.
Yeah, thanks so much. So there is another question from Chukwe Buka, but just before I ask that question, if it is possible, can I further with you the question of translation gap that you have been addressed earlier on. I think what I find really fascinating about your presentation is the fact that you did identify the key issues, the key questions we ought to ask around implementation science. One question is, what intervention is being implemented? I think that question is really fantastic and it's important. But you also did raise question about how the interventions get delivered. And I also think that is also another important question, how it fits into the needs and circumstances of partners and I guess communities. But I'm also curious to learn whether these are the only two questions we ought to ask. And I ask this question because it seems to me that there are also other types of questions that don't fall neatly into the how-ness question or the what-ness questions. And these questions are related to issues around translation gap, for example. The fact that it takes about 15 years to turn actual research findings into clinical interventions that people actually benefit from. So these questions, I imagine, impact the existence of interventions that gets delivered in the concrete, practical clinical context. And I wonder whether implementation science and their strategies are complete without also accounting for these other factors, other realities, contextual realities that have implication for the existence of interventions that are implemented. Now, what are your thoughts on this?
Yeah, such a great observation, and I think definitely speaking my language. I think my hope is that as opposed to where I think implementation science began, which was out of this idea of what we're not able to do, why isn't it that that this intervention that seems like it should be useful is not being used? That what we really are doing is informing the larger way in which we ask questions and we develop solutions that are beneficial for people. So I think for us as a team, we've been focusing a lot on how do some of these key questions in implementation science relate to the larger research enterprise? How do they relate to the larger practice and policy enterprise? And then what are the other things that we need to try and influence? We have learned a lot from our successes and from our failures of trying to implement different interventions that have implications for that whole process. So I think it's like one of those things where we sort of say, do we have a starting point that we can rally around? But ultimately, it is about expanding that terrain because there's a lot more that we think could be improved. And then that would ultimately make it easier for us to consider whether implementation is optimal or not. Does that
Thanks so much. Yeah. I also don't want to monopolize the floor, so I'll probably just go straight to other questions that have been raised. So Chukwuebuka is asking, how do we think about the issue of ethics in implementation research as it tries to optimize approaches to best deliver interventions for which we may not have the full knowledge, if they work or other effects that they may have? I think,
Yeah, really wonderful question. I think so much of that then goes to informing what are the questions that we're asking and how are we trying to answer them, right? So do we have enough understanding of the level of risk or the level of benefit for a given intervention? One of the reasons why hybrid effectiveness implementation designs arose was because there was a recognition that some of our interventions, we may not know how well they would work for a given population. And so the idea was that we need to continue capturing more information about those interventions while we're testing whether we can integrate them in our different settings. And even the idea of the type of hybrid that we're proposing is about the emphasis or the confidence that we have in that intervention. There may be some interventions where it is ethically concerning to just go ahead and implement it everywhere. Conversely, there may be interventions where it is ethically concerning not to offer that intervention to as many people as possible, given what we know about it. So I do think that it's really important that we're thoughtful about what we know and what we need to learn, and make sure that what we know, to the extent possible, influences how we design those studies, and also that we're very clear on measuring any adverse consequences of implementation. The worst thing that could happen, certainly, is as a result of our trial, there are people who do less well, who are harmed, who otherwise would not be. And so I think it's a really important question and motivates both how we design the questions and then how we design the study in order to try and limit any potential harms.
Yeah, and then when the harms, in fact, do arise, I guess this next question also extends the previous question. So when harm does arise, so this person is asking about the best approach. Do you first de-implement a harmful but useful practice? So if you have to de-implement a harmful but useful practice, should you first implement an alternative intervention, or de-implement first, or do both concurrently? And how do you, in fact, do that?
Wow. Yeah. I mean, it's a really great question, and I think it is, it's maybe easy to speculate in isolation of the specifics, but these specifics are so important, right? I mean, so much of it is based on, and I think actually this is a broader point for implementation. We should not assume that we're implementing something in a vacuum, but rather we should be very clear of what existing practice looks like. And so I think this question of whether we're de-implementing something harmful full stop, or we're substituting something, speaks to what is the need and what is the current situation, what is available, and what does it mean to stop delivering something? Does it mean the absence of something, or does it mean that there is a different practice that we're able to substitute? So I think broadly, it's such an important question, but I think the answer is probably limited without the specific circumstances.
Oh, I see. But also, is it possible also this also extends your discussion about deviations not necessarily being inherently negative? For example, if a particular intervention is shown to be harmful, and but I also agree about the context, understanding the context, understanding, getting to know the specifics, because would inform whether or not the harmful practice ought to be de-implemented before implementing the new one, or you can in fact do both concurrently. So yeah, thanks so much, Dr. David, for that question. But there is also another question. Yeah. And while I read that question, I would also ask if the IT can put up the result for the question about the number one question that we have for implementation scientists, the one you raised at the beginning of the presentation. But here is another question too, from, I think this is from Chineye. Thank you for the insightful presentation. Implementation science is incredibly dynamic. And as an early career researcher from LMIC, I sometimes find it's overwhelming to stay aligned with global expectations, especially in the absence of structured training programs. What practical advice would you offer to researchers like me for staying informed and progressing in this field?
Oh, such a wonderful question. And I would say, this group that is assembled here together is such a potentially powerful network to be able to learn from one another. And I know, I know some of the names, but it's great to see some new names as well. So whether it's through, the Alliance, or it's through global meetings, it's through trying to stay up on the literature, or even just reaching out to some of us who would love to have an opportunity to speak further. So I would say, trying to identify, of course, lead with your interests, lead with your passions, and please do reach out to any of us who makes it our job to try and support people in the field.
Yeah. Okay. Just before we go through the poll, so there's this also another question: can implementation science ever be truly neutral, or does it? Also, what's this? Or is it?
Yeah.
Mm-hmm. Yeah. Is practice fragile, conflict affected, or authoritarian? So I'm not so sure where the person is getting to with this question.
I think I understand. I think the idea is how much our studies may ultimately be shaped by specific power structures in the settings in which they're located. It's such a really good question, and I think it's a hard one to answer. I think implementation science, at best, would measure and would acknowledge the power structures as part of the context in which it's working. It is always challenging to make sure that the questions being asked are not either in the service of a very specific answer, or maybe harder to find in given settings. So I don't know whether it could ever be truly neutral. I know that that's an aspiration, but I think the ways in which we can at least minimize its bias to whatever degree is by at least trying to measure and incorporate what are the structures in which that work is set. But really great question.
Yeah.
Okay. Just let me jump in. Let me jump in, Cornelius. Two questions. The first one was the question by someone anonymous, was asking, can implementation science be applied to other sectors other than health? And the answer is yes. So say, what have we done as an organization to promote this? So we have the Nigeria Implementation Science Alliance. It's not just restricted to the health sector. It's for every aspect of research, science research, and non-science research. So we have a conference every year, and we have the call for abstract is out, and I'll make that announcement later. So go ahead, Cornelius, please.
Yeah, thank you so much, Professor Tonya. So the result I want to share with you, David, is it's concerning the number one question, the present question that folks have for implementation scientists. But this is not the result that I'm seeing. This is a different. I think this is the first poll we sent out. So if the IT can share the result for that particular, it's an open-ended question. I imagine people are supposed to type in their text, their thoughts on the questions. I'm just waiting for this to come up. Okay. Oh, anyway, it's fine. So while I wait, maybe I can also ask you a follow-up question about deviation, about how this is inherently not necessarily negative, so to say. But I wonder whether you have suggestions for knowing when deviation is necessary and why it might be necessary?
Well, I think we know about, you're saying deviation for a particular intervention from.
Yeah, from the original intervention design,
Yeah. So I know, I mean, there's a lot of ways in which we stumble upon needs for deviations. I'll give, one example. Before I came to the National Cancer Institute, I spent 13 years at the National Institute of Mental Health within the U.S., also at NIH, and we were confronted with these manualized interventions that might require 12 to 15 sessions of an individual working with a specific, mental health professional. And so many people did not have the ability to spend 12 to 15 sessions on going through this manualized protocol. And so we knew that having fewer sessions was going to be the only way that somebody could take advantage of an intervention. In some cases, as we talked about before, there might be levels of resources or information systems that an intervention is designed to use. And if those resources don't exist, then we have to deviate. I do think that there is a huge opportunity in our practice settings, in our experience, to try to identify more about those specific deviations that are needed and feed that back so that people who are developing and testing our interventions have a much clearer sense of what's the likelihood that this intervention is going to be useful or even, feasible. So, but yeah, I mean, there's definitely a lot of different room for deviation. But if we can measure where those deviations occur, and even better, if somebody feels like, you know what, I'd love to deliver most of this practice, but there may be certain things that I can't, I feel like there's justifiable deviation, and I'm going to capture information on how well the intervention that I had to deviate from still does with the way that I've modified it. So if we can learn about adaptation as it's going on, we'll be better off.
Yeah, thanks so much. Although I have many questions, so I really, really don't want to monopolize, but I'll just go straight to the results of the poll. So there are questions about funding. It is quite interesting that that's the first question that struck me. And I think maybe we can, in fact, direct that to you, given your place at the NIH. So there is a question about how to get funding for implementation research.
Yeah. So, I mean, I think what certainly, folks would be, well aware of would be different types of funders of this kind of research. There certainly have been funding opportunities that, institutions like the NIH put out. There have been many foundations that have been providing support for implementation research. There are international organizations that have provided that funding. What's been really exciting is, and there's probably an updated paper that could come, is in trying to is in seeing and then hopefully trying to chronicle all of the different sources that we've seen support implementation in the past. For the work in Nigeria, it may be something that that our wonderful hosts might be able to pull together just to share with people as to what are the current things that you all see that I may be less familiar with. But yeah, I would say there's sort of national and international sources. There are sort of more local foundations. There are also potentials within different health systems where people have been looking for, because there's a lot of quality improvement work going on, and implementation science sits nicely alongside quality improvement. There may be some other sources of local funds where you're trying to support or solve a particular local problem. But I'd probably be best to encourage that there may be a more useful version of that list for our audience.
Excellent. So it seems also that there are a variety of concepts. Oh, sorry, Professor Toya, you want to say something?
Yeah, no, I saw I just want to say what you wanted to say, which is that there are a lot of questions here, about the concept of implementation science. Seeing someone asking the difference between implementation science and clinical research. So I'm assuming that should be maybe like an early career researcher asking that question. Yeah.
Yeah,
Okay.
and there are also questions about feasibility of implementation science in low resource settings and their sustainability. People are asking about training to become competent in implementation science. The question Professor Tonya mentioned earlier on about how implementation science is so distinct from other intervention effectiveness studies, for example. Then there are also questions about how to integrate the right and appropriate frameworks into grant applications, also tied to questions around funding that you raised earlier on. Then also questions about how to help patients through, again, I believe, implementation science. So it's fascinating that they have a variety of concerns, I imagine, that span across a wide number of contexts that implementation science so touches on, from designing real protocols for grant applications to also understanding the trainings, the sort of trainings that are required to become competent in the field, and how the field itself is also distinct from other allied fields generally. So it's interesting to see this pattern in these sort of questions that people are raising for implementation scientists.
I think it's telling us something. It's telling us that David has to come back again. Maybe as a monthly webinar. David, you have to be back. Too many questions for you today.
Well, so I think I'm right, depending on when people were asking these questions, in saying that some of these questions, hopefully the person who put it down as their top question feels a little bit better than they did before in an answer. The second thing I would say is that you all have this incredible access over the remainder of the week to be able to engage with a lot of other experts who can help to further answer these questions. And then the third thing is, I'm generally pretty easy. I'm happy to follow up with anybody. And so if you want to follow up with me and have a chat, if I have not done my job and you feel like these questions, if anything, have gotten more pressing and worse as far as a response, then please reach out and we can improve upon that.
Okay, thank you. So we're down to the last issues, which are the announcements, and one of them would be can you stop sharing so we can share this? So the Nigeria Implementation Science Alliance has a conference. We have a conference in September, and the call for abstracts is now. So I'm sharing the call for abstracts, and it ends this week, unfortunately, on the 6th, which is Friday. Please, 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 we've been sharing this on a lot of platforms. This is our 10th year of the Nigeria Implementation Science Alliance since our Professor Echezona Ezanolu founded this together with the CEOs of various implementing partners and policymakers in Nigeria. It's been one level of success to another. So a good place to attend for the individual who is asking the question, is this all about health? No, Nisa is not all about health. Nisa is also for the non-health disciplines. And if you have an abstract, but it cuts across implementation science and is non-health, we'll be happy to grab it with two hands. Just send it in. So, and then the last announcement I have to make before we quickly run along, we have just 2 minutes, is that we know that the week continues tomorrow. So tomorrow we'll be looking at research training and capacity building. And that's what David was alluding to, that we have a lot of questions that can get answered even as we go along the week. So the same link that you used to join today is going to be available for you to join tomorrow at 4 p.m. and we stop at 6 p.m. just like we're about to do in 2 minutes. We'll be having very seasoned researchers, going to have early career researchers, mid-career researchers. They're going to talk about the research they're doing, the research they've done, and how you can engage yourself if you're interested in some of those grants. So please, please, please make it a point of duty to be here with us at 4. Share, spread the word, and be with us at 4 p.m. tomorrow so we can enjoy research training and capacity building. Once again, David, thank you so much. On behalf of the Nigeria Implementation Science Alliance and the Ivan Research Institute Nigeria, Cornelius and I are saying a big thank you. Everybody on this call now is saying a big thank you. And of course, we want you back again. So your last parting remarks, David, for us, words of advice.
Just to say thank you. Like I said, I mean, it can be a lot at times because for all of us, there's a lot of complexity here, and there's a lot of really important work to be done. And so, just the idea that so many of you have been willing to join us and stay into the early evening means so much. And so again, we're here to try and be as supportive as we can. But I'm just grateful to all of you and keep asking those questions because we need the answers, right? We need to figure out how to better support everybody's health and healthcare.
Thank you so much, David. So thank you, everyone. Our IT will share the link to the abstract submission so you can send in your abstracts on the chat. Thank you, everyone. See you tomorrow. Thank you. We appreciate you all. Bye-bye.
Bye. Bye. Keep well, everyone. Yeah. Bye.
Yeah.
So, Dr. David, while we're still waiting for everybody to leave, I wonder whether do you still keep or you still or you?
Oh, unfortunately, I have not been on a football team in a while. So I've been a soccer parent for the last 14 years as opposed to a soccer player. I still play tennis. That's my primary sport. I'm a tennis player, so I still play tennis and I run, but I haven't actually been on the pitch for a while, except on the sidelines. Yeah.
But I think it's managed to nurture that interest. You said you coach. No, I think that's fascinating that you.
No. In fairness, I support my son, but